Coverage of the ASH conference in Orlando, Florida continues. I'm Thomas Baldrick. Happy to have with us Dr. Alison Moskowitz from the Memorial Sloan Kettering Cancer Center in New York City. Thanks for stopping by.
Thanks for having me.
Let's talk about your work here. TARC predicts PET-Normalization and event-free survival in relapsed refractory Hodgkin lymphoma patients treated with Brentuximab. Can you talk about the design of this study before we get into the results?
Sure. So this was a phase 2 study in which we treated patients who had failed their frontline therapy for Hodgkin lymphoma. The goal of the study was try to normalize their PET scan before going to transplant, because that's one of the most important prognostic factors for patients going to transplant. So patients were treated with PET-adapted therapy, in which they first received 2 cycles of Brentuximab Vedotin. And for those who had a normal PET scan after that, they went right to transplant. And those with persistent abnormalities on PET scan, they received additional chemotherapy with augmented ICE for 2 cycles, followed by another PET scan and then consideration for a transplant. So we've already reported the results of this study and found that the patients who had a negative PET scan before transplant, as we expected, did quite well. And it didn't actually matter whether they only needed Brentuximab in order to become PET negative or whether they required additional chemotherapy with augmented ICE. As long as they achieved normalization on their PET scan, they did quite well. Now, the patients who had a positive PET scan who went to transplant, about 50% of them ended up being cured, which was actually a little better than what we would have expected. And so the subject of this report was looking at other factors that might have helped distinguish who were the even higher risk population and who maybe could have been patients who could have been distinguished as who may not have done as well if they had gone to transplant.
So what were some of those other factors?
So we specifically looked at serum markers and drew these at baseline as well as after the 2 cycles of Brentuximab. And we looked at various different cytokines and chemokines. So the cytokines we looked at are interleukin 6 and interleukin 10, interferon gamma, and in addition we looked at the chemokine TARC, which is a marker of, which is a chemokine that is released from inflammatory cells, and it attracts certain inflammatory cells during a normal inflammation. And it turns out that this is very highly secreted by the tumor cells in Hodgkin lymphoma, and so possibly a biomarker in Hodgkin lymphoma.
Let me ask you what you think the clinical implications are of this study.
So the nice thing about TARC is that, and the various other cytokines, is that they can be detected in the serum. So there's something that we can check on a patient at the time of starting treatment, and we can also follow these markers after treatment. And what we found were more than any of the other cytokines, the TARC was the one that was the highest in the patients at baseline and had this most significant reduction after treatment with Brentuximab. And the patients who had the highest reduction in TARC were more likely to become PET negative, who were most likely to be in the group of the patients who became PET negative with just Brentuximab. The other thing that we found, that the patients who had a very high TARC level even after Brentuximab were more likely to be the patients who did not do as well following transplant. And so all of the patients who ended up progressing or having their lymphoma come back after transplant on this study all happened to be in the group of the patients who had a higher than the median TARC level. So it ends up, in this study, it seemed to be a biomarker to help predict who are the patients who possibly needed more therapy or a different therapy on the study.
So where do these findings lead you next?
Well, we do have some additional patients that we are going to be looking at this as well, who were in a different cohort on the study, and so we'll be adding to this series and see if the results still pan out. And I see this as something that we need to be looking at in all prospective studies that we're doing in Hodgkin lymphoma, including the frontline studies as well as second-line studies, because I do think that this is an important biomarker and potentially will help us distinguish which patients actually have false positive PET scans as well as potentially false negative PET scans, and may help us better distinguish which patients should be eligible for less intensive therapy as well as more intensive therapy.
Sounds good. Thanks, Dr. Moskowitz. Thanks for joining us.
Thanks so much.